على بركة الله. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening everyone and welcome to the Iraqi Stroke Network educational webinar series. All our webinars are endorsed by the MENA Stroke Organization and this is our 22nd educational webinar. And today's session is focused and very highly practical and it will concentrate on mechanical thrombectomy tips and tricks. My name is Mustafa Alshahni. I'm a neurologist at Diwaniyah Teaching Hospital, and I will lead this session tonight in association with my friends and my colleagues, Dr. Fatima Ghanem and Dr. Gazwan Altaee. So, Dr. Fatima will lead the Q&A section. Please, Fatima, go on.
Good evening. My name is Dr. Fatima Ghanem Al-Shaybani. I'm a resident in neurology at Diwaniyah Teaching Hospital, and I will be leading the Q&A session at the end of Dr. Mustafa lecture. Please feel free to post your question in the chat box, and I will during the talk, and I will read it aloud. But if you want to ask the question verbally, you can use the raise function feature, and thank you.
Thank you very much. Thank you very much, Dr. Fatima. So before introducing our guest speaker, we will start with a short scientific introduction to the topic to frame today's discussion and align our clinical thinking. This introduction will be delivered by our panelist, Dr. Gazwan Altaee. Dr. Gazwan is a neuroendovascular surgeon in Karbala. Dr. Gazwan, please, the word is yours now.
Thank you, Dr. Mustafa, and thanks for all of the attendees. Do you hear me, please?
Yes, Dr. Gazwan.
Hello, Dr. Mustafa. How are you?
Alhamdulillah. Nice to see you all.
Yes, it's very nice to meet you, sir. I want to say some words about the conditions or the situation of stroke in Iraq. As you all know, stroke is one of the most important debilitating disease. It's a main cause of morbidity and mortality worldwide. As you know, ischemic stroke comprises about more than 85% of all strokes. Unfortunately, in our country, we have a limitation in the number of stroke units or stroke centers, and even in the experts of the neuroendovascular interventions. Unfortunately, we don't have a good number of certified neuroendovascular interventions. That's why we plan with the ministries of health and higher education to establish a training program related to Arab or Iraqi board, and also need to establish a new centers, whether primary or comprehensive stroke centers, to deal with these important topics and diseases. So it's my pleasure to meet all of you, especially Dr. Mustafa Mahmood. I think the last time we met was in Erbil last month.
Yes, that's correct. The pleasure is mine, sir.
Thank you, sir. It's very nice to meet you. And now the word is yours to present your nice words. Thanks very much for you.
Thank you very much, sir. Let me have the honor to introduce our guest speaker, Dr. Mustafa. So, Dr. Mustafa Mahmood Ibraheem graduated from medical school in Egypt in 1993, and he became a radiology resident in 1995 at Ain Shams University in Egypt. He began his career in interventional radiology and interventional neuroradiology when he joined the residency program in France from 1998. He completed his clinical fellowship in interventional neuroradiology at Montreal University Hospital, Quebec, Canada in 2007. He launched the INR service at Dr. Sulaiman Faqih Hospital in Jeddah, Saudi Arabia, as a visiting consultant between 2007 and 2021. He became an assistant professor of interventional neuroradiology in Cairo, Egypt, and director of the INR units at Ain Shams University in 2008. Later, becoming a professor in 2014. He has published many articles in well-known journals specializing in the INR field, contributed to writing chapters in books, and practiced in multicentric research projects. He joined Hamad Medical Corporation as a senior consultant and director of the INR unit in 2022. MashaAllah, very nice career. The word is yours, Dr. Mustafa, now. Please
Thank you
share
so
your
much,
screen.
Dr. Mustafa and respected colleagues. It's an honor to present this presentation in your respected webinar. And let me express my extreme respect and appreciation to the manner you are organizing this gathering. And as far as I know, it is held on regular basis. So I will begin my presentation. Just a second. So can you see it now?
Yes.
Okay. So my topic today is focused on the tips and tricks in mechanical thrombectomy and how to decide in different circumstances.
Well, sir, I can't see your screen.
Now it's okay?
Yes, it's good.
Okay.
So, Dr. Gazwan, you see the screen? I cannot see it.
Sometimes
Problem.
Dr. Mustafa appears and sometimes disappears. But now it's good. I think now it's good. Yes, sir.
Now you
Please.
can see the aspect score or not?
No, just your picture. Just your video.
No, I think there is disconnection, some sort of disconnection. Now can you see or not?
Dr. Mustafa, just do share if you can.
Okay, just a second, because I did.
Just get out and share again. Will count.
Okay, I will do. Okay.
What's your name and what job are you just put in today?
Now it's okay or not?
Yes, now it's good. The presentation is okay.
Okay, you can see the presentation, the first slide.
Yes.
Yes,
Right?
exactly. Yes.
Okay, perfect. So thank you again, respected colleagues, for having me among you today. I will try to be as fast as possible, and I will focus on things I see in my perspective that it's important. So just to begin with, can you see the aspect score in color?
Yes.
Okay, perfect. So I will just begin with the aspect score. As you all know, we are depending on the Alberta score for evaluating the magnitude of stroke on a plain CT. So it is divided into 10 points. Every part will take 1 point from the caudate nucleus, the lentiform nucleus, the internal capsule, the insula, and as you can see, M1 is the frontal part of the operculum, and M2 is the anterior temporal lobe, then M3 is the posterior temporal lobe. 4, 5, 6, it superpose with the row, the first, the M1, M2, M3, just one level above. So M4 corresponds to M1, one level above, M5 corresponds to M2, one level above, and M6 corresponds to M3, but one level above. It is different than the posterior circulation, because the posterior circulation has a different aspect score, one for each posterior lobe, one for each cerebellar lobe, one for each thalamus, 2 points for the midbrain, and 2 points for the pons. I would like just to highlight that the aspect on a CTA source image might be more appreciated than on a plain CT. Just have a look on row number A, which is a plain CT, versus plane B, which is a source image CTA, and row number C is a late, or let's say 24 hours CT. Row number A, can you give me a score for the aspect? I would give it, maybe if I'm generous, I will give it 9. But actually this is not true, because when you go to the source image CTA, you can appreciate a hypodensity here, and I have another hypodensity here, and hypodensity here and there. When you compare it to the 24 hours CT, look at this. It coincides perfectly with the source image CTA. This hypodensity, you can appreciate it here, and this hypodensity, you can appreciate it here. So we are depending, in Hamad Medical Corporation, of course, we will start by having a look on the plain CT, then we will combine that with the source image CTA to make sure that we are not missing or miscalculating the aspect score. I would like to draw your attention first for the ghost infarct score. We are very aware in Hamad Medical Corporation with the ghost infarct score, which is an overestimation of the CBV in the early phase of the stroke. This early phase will lead to a miscalculation of the CBV. It will appear on your scan exaggerated, in contrary to the reality. And this is not rare, because it accounts, as you can see here, from 6 to up to 60% in the first 6 hours. So in the first 6 hours, we are expecting that the CBV might be exaggerated. So what is the importance of the ghost infarct score? Sometimes you will deny treatment. You will deny offering treatment. You will be reluctant to offer treatment to candidate patients if you are depending solely on the CTP. And you will be misled probably by the exaggerated CBV. So let's go and review our cases. Case number 1 for a 55-year-old gentleman presented with sudden onset of headache, left side weakness. Patient was witnessed, and it was in Ramadan at 6 p.m. when he showed a left side weakness, right gaze. Upon arrival to the ED, there was obvious homonymous hemianopia, aphasia. CT and CTA and CTP were done at 7:20 p.m. Altaee was administered. Look at the CT. This is the plain CT, non-contrast CT, obviously you can see a hyperdense sign in the MCA. But look at the aspect score. What do you think about the aspect score? Good, not bad.
Yes.
If I'm generous, I will give him maybe 8. But look at the CBF and CBV. It is a matched defect, matched perfusion defect. But please be aware about the timing. This patient arrived within 2 hours from onset of symptoms. And this is the source image, CTA. What do you think? It's already gone. It is a high aspect score. It is a low aspect score as compared to the plain CT. Look at the plain CT here and the matched defect in the CBF, CBV, and the source image, CTA. Great discrepancy between the plain CT, which shows subtle changes, as compared to the source image CTA. So please keep in mind the source image CTA. It will give you a clue. However, this patient arrived in the first 2 hours of symptoms. So when you compare here is a plain CT and here is the source image CTA. Here is the M1 occlusion, obviously an M1 occlusion, and obviously he has 0 collaterals. So first pass, first shot, adapt technique, full recanalization. First 2 hours, whatever the CTP is, whether it is matched or not, we will consider it a ghost infarct core. It might be a very low aspect score, but admitting a patient in the first 2 hours, or let's say in the first 6 hours, whatever the CTP is, we have to go for thrombectomy. Because we are backed by 2 facts. If the CTP is real, so you are depending on the large core trials. If the CTP matched defect is not real, so it is a ghost infarct core, and the patient will get benefit of the revascularization. Unfortunately, this patient did not get benefit of the revascularization because this is a plain CT 24 hours, which coincides perfectly with the source image CTA previously reviewed. Case number 2, for a 59-year-old lady, hypertensive, diabetic. She presented in the first 3 hours, less than 3 hours. Upon arrival, there was a documented left M1 occlusion, very high NIH of 18, so we proceeded for mechanical thrombectomy. Here is a non-contrast CT. What about the aspect score? Aspect score is good. It is not very low. I will give this aspect score maybe 7 or 8. It is very subjective as well. So here is a CBF and CBV. Obviously, it is a matched defect. We will consider it a ghost infarct core. Till proved otherwise. Till proved otherwise means go for thrombectomy. So this is a penumbra map, and here is a source image CTA. You may say it is blackish here and there, but go ahead for thrombectomy because the patient is presenting within the first 6 hours. She will undergo thrombectomy anyway, whatever the CTP result is. So Here is the M1 occlusion and first pass revascularization. Here is a 24 hours CT. Obviously, it was a GIC. Obviously, what we were reviewing initially in the CTP is a ghost infarct core. This matched defect was a false matched defect, and we are speaking about a GIC, which has a probability of 6 to 60% in the first 6 hours of presentation. So this matched defect was not, sorry. Another case of a left M1 occlusion in a patient presented in the first 6 hours. So obviously here you can say that it is this is a source image CTA, relatively blackish, and we will proceed for thrombectomy anyway. There is an ICA occlusion and MCA occlusion concomitantly. So as you can see, there was a critical stenosis in the ICA origin, successful angioplasty, and then we just opened the door, and then an M1 occlusion, first pass revascularization, and here is the 24 hours MRI. So as you can see, I will repeat it again. This is the result after 24 hours, an MRI. So obviously it was a GIC. It was a ghost infarct core. The patient presented in the first 6 hours. Whatever the CTP result, we will go for recanalization and thrombectomy because those patients were denied treatment, and obviously they are getting benefit. Look at the MRI. If you were depending just on the CTP and the patient has been denied treatment, he might be in a very bad neurological status after 24 hours. So another case for a 56-year-old gentleman fell down while walking in the park at 6:30 a.m. Homonymous hemianopia, right gaze, left side hemiplegia, neglect, NIH very high. CT showed the right occipital hematoma, most likely because of his trauma, so no thrombolysis. Groin puncture, he fell at 6:30, groin puncture at 8:17, angioceal at 8:29. Angioceal means that we ended the procedure. The procedure was finished by 8:29, 12 minutes procedure. Plain CT, obviously there is hyperdense sign in the MCA, and a typical matched defect. We will go for thrombectomy anyway, whatever the CTP result is. It is a matched defect, but it is not real. It is a false matched defect. It is an over-exaggeration of the CBV because of the GIC, the ghost infarct core, which has been published in 2017, nearly 10 years ago. We are very minded by the GIC in order not to be reluctant in offering treatment for a patient who might get benefit from. obviously an M1 occlusion, and you can see here our technique, which has been published in last year in Journal of Vascular Interventional Neurology. We are just advancing the Teromo 35 wire, but we never cross the bifurcation, just to mitigate and facilitate the tracking of the aspiration catheter to cross the ophthalmic artery ledge. Look at this. Here, we are just using it as a lever, the sheath, and here it was on a lateral view, and on an AP view, just never to cross the bifurcation, and up the aspiration catheter will go to the target. Sorry? I'm sorry? So here is a final result, AP and lateral view, and here is the 24 hours MRI. Look at this. What is that? It's a cortical laminar necrosis, which is just the insult touched the gray matter and spared the white matter. It is a cortical laminar necrosis affecting just the cortex. Of course, it is not a brilliant thing to get for the patient, but it is way better for the patient to get just a cortical laminar necrosis instead of infarcting the white matter as well. The white matter has been spared, only the gray matter was affected. The prognosis is way better. At least you will never get a malignant edema. Those patients will never be in need for a hemicraniectomy. And the prognosis, this patient recovered after 2 days. He was capable of lifting his arm and leg against gravity. So, of course, it is not a very good thing to get, but it is way better than getting an infarction affecting the gray matter and the white matter. Typical cortical laminar necrosis. So, should we follow the CTP and focus solely on the mismatch between the CBF and CBV? No, especially in the first 6 hours. Should we monitor the aspects on the native CT and the source image CTA? It is not a sin to depend on the aspect score on the native CT. I'm just reminding my respected colleagues that Mr. Clean was depending only on a native CT. So should we focus only on a collateral circulation? Our protocol in Hamad Medical Corporation, first we have 3 pillars to build up our decision. First is the time. Below 6 hours, the patient is witnessed sure of timing, we will go for thrombectomy, whatever the CTP result is. Aspect score on the native CT and the source image CTA. Between 6 and 12 hours, or even more than that, we observe a favorable aspect score on both native CT and source image CTA. If there is a favorable aspect score 6 and above, we will proceed with intervention. CTP, if there is an evidence of a poor time window, unfavorable aspect score with a significant mismatch, we will proceed for intervention. However, if unfavorable aspect, insignificant mismatch, we will refrain from intervention. So what about, you will comment maybe about what is the role or the place of large core trials. As long as the trials have been published, so we have to lean and to obey the literature. I will just remind you that the first one was Rescue Japan in 2022, randomizing patients with aspect between 3 and 5. I will summarize all of them in one table, so don't bother with that. Then came Angel aspect in 23, then Select 2, then Tension trial 23, then last trial in 24, in May 24. So please have a look on this table. These are the trials for large core strokes. And as you can see, Rescue Japan, aspect score of 3 to 5, Angel aspect 3 to 5, Select 2, 3 to 5, Tension 3 to 5, last 0 to 5. So they did include 0, 1, and 2, which is a black hemisphere, within 6 hours, of course, within 6 hours. So the longest ones were Angel aspect and Select 2. And look at the MRS. So 14% for mechanical thrombectomy in Angel aspect, 30% in Rescue Japan, 14%, 30% in Angel aspect, MRS 0 to 2 in 90 days, completely independent patients, relatively independent patient, let's say, Select 2, 20%, Tension trial, 17%, and look at last, 13%. This decline might be because they included 0, 1, 2, very low aspect. And the death rate is roughly arbitrary, is around 20%, 18% in Rescue Japan, 21 in Angel aspect, 38 in Select 2, 40 in Tension, 36 in last, and the symptomatic intracranial hemorrhage. We might expect that there was a great discrepancy or a great rise of symptomatic intracranial hemorrhage in mechanically thrombectomized patient versus best medical treatment. But obviously, the difference was not huge, sometimes statistically significant, but it was not huge. 21, look at Angel aspect, 21 in mechanical thrombectomy versus 20% in best medical treatment. 6%, 0.6% in mechanical thrombectomy in Select 2 versus 1%. 5% in Tension trial for both. Last trial, 96 for mechanical thrombectomy versus 5.7 for best medical treatment. And the rate of hemicraniectomy was arbitrary, around 10%. Another case for a 64-year-old gentleman, diabetic, hypertensive, coronary artery disease, dyslipidemic, NIH 13, left homonymous hemianopia, left side weakness, and aphasia. CTA, CTP, CT, CTA, and CTP reported a right MCA territories mismatch with ICA occlusion. Thrombolized. Look at this. Here is the non-contrast CT, plain CT. Aspect is not bad. Look at the CBF, the CBV. Little bit weird. Look at the Tmax and the time to drain. I can see that it is mostly in the occipital lobe rather than at a pure MCA territory affection, despite that the ICA was occluded. Look at this, mostly in the occipital lobe. So we proceeded for mechanical thrombectomy. Here is the AP view, an ICA occlusion. But the CTP, the MCA territory, was not that much affected. It was not a striking MCA CTP matched defect. It was rather a right occipital lobe affection. So look at this. Here is the lateral view. Here, sorry. I'd like just to highlight that. Here, you can see the ophthalmic artery. Here is the ICA. Nothing going in the hemisphere, just the ophthalmic artery. So, with a stent retriever, we put a stent retriever. We discovered that there was a fetal PCA, which was revascularized after the stent retriever thrombectomy. So what to do? To go further? To recanalize the ICA, despite that the CTP was pointing to you that the MCA was good. Here, I said, I have to go to the contralateral side to have a look on the left ICA. Sorry. And here is the left ICA. The left ICA is vascularizing the right hemisphere via the ACOM. So stop here. No need to go further. Just you did the job. You revascularized this artery, which was the main complaint of the patient, the PCA. And from the contralateral side, no worries. There is a cross hemispheric revascularization because of the chronic occlusion. So another case for a 50-year-old gentleman, onset 1510, partial facial palsy. The ED, there was a partial facial palsy, right upper limb drift, limb ataxia. CTA was done at 17. At the INR, he became aphasic, looking for his words. ICA occlusion, as you can see in an AP and lateral view angiogram. Still ICA occlusion, terminus, and MCA occlusion. Then adapt technique, just aspiration with a Sophia Plus. We revascularize the hemisphere. What do you think? Is it good or bad? Look at this. Look at this perfusion defect here and there. What you are seeing here is that we vascularize the MCA and the ICA, but the whole ACA is missing. What you are seeing is the contralateral ACA, and the whole ACA is missing. And what drew our attention is the perfusion defect, the whitish discoloration of the angiogram here, pointing to a perfusion defect. Here is the AP perfusion defect, completely white here. And look at the angiogram, the same angiogram, but in a lateral view. This is the contralateral ACA. And look at the ipsilateral ACA. There is a cut off here at the ACA. So we went for revascularization of the ACA. This was before revascularization, and here is after revascularization. Obviously, full revascularization of the ACA using the same technique, aspiration only. And here is the lateral view. You can see both ACAs are visualized distally, 1 and 2. This is the contralateral one, and this is the ipsilateral one, which was occluded in the initial angiogram. And here is the MRI after 24 hours. Not bad, huh? For the sake of time, I will go further. 91-year-old gentleman, coronary artery disease. He was alert, responsive to time, place, NIH very low. And he has mild dysarthria. Here is the CTP, another very important tool for the CTP. Look at the CBF, the CBV, and the Tmax. Look at the discrepancy between the Tmax and the CBF and CBV. This discrepancy will point always to a chronic occlusion. When you find a discrepancy between the Tmax, like that, and the CBF, which is very light affection in the CBF, nearly normal CBV, and highly affected Tmax and time to drain, this will point towards a chronic occlusion. And as you can see, there is the MCA is visualized here, but the ICA was missing, and we did nothing for this patient because of the imaging interpretation. Tmax, CBF, and CBV discrepancy pointing towards a chronic occlusion. So to intervene or not, the key point is the NIH. Low NIH, do not intervene. High NIH, intervene. And here is the MRA, and this is the source image. Obviously, you can see a stenosis. Look at the discrepancy between the ICA here and there. It is a chronic stenosis. So we did not intervene depending on this imaging interpretation of the Tmax, CBF discrepancy pointing towards chronic occlusion. Another one data missing. How about the NIH? Low or high? Low NIH of 4, do not intervene. This is the Tmax mismatch ratio to identify intracranial atherosclerotic stenosis related large vessel occlusion. So another one, 44-year-old gentleman, left side weakness grade 0, NIH of 14, high NIH, discrepancy between Tmax, CBF, and CBV. the same imaging of the previous case, but the only difference is the NIH. NIH was 4 in the previous case, here is 14. So to intervene or not? Of course to intervene. So here we are almost sure that there is a stenosis, there is an underlying stenosis, and that's why we put a stent, as you can see, and we did not do a post-stenting angioplasty. And look at the 24 hours CT. Here is a 24 hours CT, only ganglionic infarction, and most of the MCA territory was saved. So, thrombectomy decision-making in HMC. Large course stroke in the first 6 hours, we interpret it as a GIC, whether there is a hypodensity evident in the source image, CTA or CTP. Large course stroke aspect 3 to 5, presented between 6 and 16 hours, we will proceed for thrombectomy. Large course stroke 0 to 2, presented between 6 and 16 hours, decision will be tailored case by case. Honestly, I am very reluctant to go for aspect 0 and 2. Discrepancy between Tmax and CBF, low NIH, conservative management. Discrepancy between Tmax and CBF with high NIH, stenting. Last case for a 41-year-old gentleman, presented at 7 p.m., facial deviation to the left, mild right arm weakness. At 8 p.m., his arm weakness totally recovered. NIH 3. Here is the CT. Some hypodensity here and there. Aspect of 7, maybe. And here is the CTA. Look at the CTA. Obviously, here, ICA is studied with clots and M1 as well. And there is no ICA, very faint ICA. But then IH 3, to intervene or not. I did not intervene. And here is the CTP, CBF, CBV, mismatch, but NIH of 3. So we are not treating images. Tmax, high, affection. We are still in a very low NIH of 3. At 8:30 a.m., there was significant deterioration, partial gaze, sensory affection, dysarthria, NIH of 8, right arm drift. We did just CT to make sure that there is no bleeding, and we rushed to the angio suite. What we found in the angio suite, flame-shaped sign pointing for dissection. Always this flame-shaped sign in the ICA, it points towards ICA dissection. So we advanced our Bobby catheter. You can see obvious dissection, long segment of dissection here, stenosis here, and the long segment of dissection all through from the origin till this segment with obvious M1 occlusion. Same technique, adapt technique, tracking the aspiration catheter with the aspiration catheter was not easy to track, so we refer to what we call it anchoring technique by deploying the stent retriever and then advancing the aspiration catheter. aspirating while occluding the flow from the bobby, full recanalization. And what about the dissection? We have to stent. So we stented the whole segment from here to there, because all this segment is dissected. And as you can see, 3 stents were deployed in a telescopic fashion to regain full flow in the ICA. And here is a 24 hours follow-up CT. Obviously, most of the MCA territory has been saved, apart from the initially present infarcted tissues. Thank you so much. If you have any question, I will be more than happy to listen and answer.
Thank you very much, sir, for this interactive session and vibrant lecture, actually. Now we move to the panelist comment. So, Dr. Gazwan, do you have any comment, please?
Yes, thank you very much, Professor Mahmood, for this very nice presentation. Actually, I have many questions. I'll try to be short to ask some of them only.
Please.
So, if the patient is presented within 6 hours, so do you think there's a great necessity for doing CT perfusion, or we can just shift to the mechanical thrombectomy if the other criteria is enough?
Yeah, I got your point. I would like to remind you that, sorry for that. I would like to remind you that Mr. Clean was totally dependent on the plain CT. So it is not a sin to depend on the plain CT. However, in my humble opinion, CTP is a must, because CTP will give you a clue. For instance, if you have a Tmax CBF discrepancy, this points towards a chronic occlusion, underlying stenosis, or an underlying cerebral artery disease, CAD. So it will give you a clue, which is a very important clue. So if you have the option of doing a CTP, why not? If you don't have the option, it is not a sin to rely on the non-contrast CT.
Yes. Okay. The second question, sir. If we have a tandem lesion, so do you believe in the antegrade versus retrograde revascularization? Do you think first we do the thrombectomy, then stenting of the proximal ICAS lesion, or we first doing stenting, then we go upward to do the thrombectomy for the MCA? Which one of them?
There are fans for both opinions, for each one.
Yes, it's a debate, so I am asking you about the
and there are fans for each opinion, but I'm speaking for myself. In my humble opinion, I prefer to go to open the MCA first and lastly stent the ICA.
Because time is the brain, right?
Yes, that's correct. But I am not opposing the other group.
Okay. Third and the last question I'll do it. If we have an ICAD in the MCA, so
Yes.
after doing aspiration or stenting and you see a severe stenosis, do you believe in putting a stent in the MCA before getting out, or you leave it without stenting after doing thrombectomy?
If there is an underlying stenosis,
yes,
I have to put a stent. If
Okay,
there
which
is an
type?
underlying stenosis, go for stenting. It will not remain open, because if you, and I have another trick after putting a stent. I have to wait for nearly 20 minutes just to make sure that the stent will not occlude again. Of course, after giving integralin, I have to load the patient with integralin, then start the integralin infusion, and then put a stent.
Okay, so which type of stent do you prefer?
Whatever stent you have, put whatever you have. They work, all of them, they work. If you have a solitaire AB, it works. And Uniform Atlas, it works. Credo, it works. Coronary, it works. Whatever stent you have, go for it.
Okay, thank you very much, Professor, for this nice presentation and answer.
Always a pleasure.
So, Dr. Mustafa, the word is yours.
Thank you very much, sir, and for your nice comment. Now we move to the Q&A section that will be led by my colleague, Dr. Fatima. Please go on, Fatima.
Thank you, Dr. Mustafa. Actually, it was very informative lecture. Now we will move to the questions by audience. The first question is from Dr. Surud Georges. He's saying, what's your practice in the posterior circulation ischemic stroke with the LVO?
Yeah, it is still off-label. It is still off-label, but we are doing it. Whenever we are facing a basilar occlusion, we will go for it. We are currently looking back to our data in HMC in the last 10 years. And the results are not very bright, let's say, but we will publish it soon. Very soon we will publish that.
Yes, thank you, Doctor. Another question is from Dr. Mustafa. Dr. Mustafa, he's saying, what's your opinion about doing MT in the low aspect after 6 hours? You have well tackled this issue in those less than 6 hours.
For a low NIH score, right?
Yes, sir.
Yes.
We don't know. We are just awaiting 2 trials, which are ENDOLOW and MOST trial. They are about to be published, and maybe in the current year we will know the answer, because actually till now we don't know, and we are not justified, because it is scary to go for low NIH score while we are not backed by the literature. Because imagine if you go for a low NIH score of 3 or 4, you do thrombectomy, you get an inadvertent thromboembolic event, and the NIH climbs from 3 to 16.
Yes.
So we are just awaiting MOST trial and ENDOLOW. We will get the answer.
Yes, thank you, Dr. Mustafa. No more questions. Dr. Muna, the word is yours, and thank you.
Thank you very much. Thank you very much, Dr. Fatima. And on behalf of the Iraqi Stroke Network team, I would like to express many thanks to our guest speaker, Dr. Mustafa Mahmood, for his excellent and insightful and highly practical session. And also, I would like to extend very much thanks to our panelists, Dr. Gazwan Altaee, and all our audience for their participation and enrichment of the discussion. I would like also to invite our audience to join our network if we are not do yet, and your feedback is always welcome and help us continuously improve our educational activity. And finally, I'd like to sincerely thank Abdi Ibrahim Pharma for supporting this webinar and thank you again for all, and have a good night.
Thank you.
Thank you
Thank you
very
so
much.
much. Thank you.
Thank you
Assalamu
very much.
alaikum.
عليكم
Thank you,
السلام
Dr.
ورحمة الله.
Thank you.
Thank you,
Salam.
Doctor.
Assalamu alaikum.
Thank you
Goodbye.
very much. Have a good night.
You too.